This is Ian Bodford.
And Lang Liu.
And welcome back to the Clinical Correlation. Today's case is...
This is an 80-year-old Chinese female with past medical history of hypertension and coronary artery disease with previous stents placed. She presents via EMS with her daughter, complaining of mid-sternal chest pain and shortness of breath.
EMS reports the patient was noted to have ST elevations on her EKG and was given 325 milligrams of aspirin.
Her daughter reports that the pain started 30 minutes prior to arrival. The woman's husband unexpectedly passed away this morning, and she was watching his body being taken away when she had sudden onset chest pain.
The patient's vitals were stable, and here's her EKG via EMS.
In addition to reading of abnormal EKG across the top, you note ST elevations in V3, V4, and V5 with T-wave inversions in AVL, V1, and V2.
Given the patient's risk factors, clinical picture, and EKG, you activate the cath lab.
Though definitely not necessary prior to cath lab activation, your nurses were proactive and were able to send for labs. The patient is already in the cath lab when her labs return.
She is noted to be hyperkalemic with an AKI and a troponin elevation of 1.15, which peaked roughly 6 hours after onset of symptoms.
Her cath report shows clean coronaries and patent stents with severely depressed LV systolic function and anterior apical and inferior akinesis.
Sure sounds like Takotsubo Cardiomyopathy. She was brought to the ICU and the cardiologist was called to the bedside for a code blue.
She was in PA arrest and was treated with atropine just prior to losing her pulse. CPR was initiated and she achieved ROSC.
On regaining her pulse, she was in cardiogenic shock with blood pressures in the 60s and a pulse in the 40s requiring pressor support.
She did well and she was discharged from the hospital on day 7 without any additional significant findings.
Takotsubo Cardiomyopathy, or TCM, also known as broken heart syndrome, is a transient cardiac syndrome in which there is apical akinesis of the left ventricle.
More than 90% of reported cases are in women ages 58 to 75.
It mimics ACS and is characterized by chest pain and dyspnea, triggered by a significant emotional or physical stressor, such as the unexpected death of a loved one or an acute medical illness.
Reported triggers also include the anniversary of the death of a close family member, witnessing an accident, loss of a job, being in court, lightning strikes, public speaking, fierce arguments, intense fear, and a surprise party.
Proposed mechanisms include multi-vessel coronary artery spasm, impaired cardiac microvascular function, and endogenous catecholamine-induced myocardial stunning and microinfarction.
To diagnose TCM, the patient must satisfy all 4 conditions in the modified Mayo Clinic criteria at the time of presentation.
EKGs in patients with TCM can have repolarization changes including ST elevations, QT prolongation, and T-wave inversions.
A troponin is elevated in 95% of patients, and serum catecholamines are found to be 30 times normal levels.
Diagnosis is made when the patient undergoes cardiac angiography for presumed MI and is noted to have no significant coronary artery stenosis and left ventricular apical ballooning.
The condition was first discovered in Japan and is named after the Japanese term for octopus trap due to the shape of the left ventricle on imaging.
Our patient's echo showed normal left ventricular cavity size. It also showed anterior apical and inferior apical akinesis and normal basal wall motion.
She had moderately depressed LV systolic function with an EF of 35 to 45%, and tissue Doppler was consistent with diastolic dysfunction.
Typically, abnormalities in systolic function and ventricle wall movement resolve in 1 to 4 weeks, and most patients recover fully within 2 months.
Death is rare, but heart failure occurs in about 20% of patients. Rarely reported complications include arrhythmias due to QT prolongation, left ventricular outflow tract obstruction, and rupture of the ventricle wall.
ED management in TCM is easy. Activate the cath lab.
TCM is indistinguishable from a STEMI in the ED. No criteria can be safely used to differentiate between the 2 conditions. You should activate your local code STEMI protocol.
This includes your typical agents for management of a STEMI: aspirin, beta blockers, nitrates, anticoagulation, and morphine.
Patients in acute heart failure may require diuresis, and patients with cardiogenic shock may require resuscitation with IV fluids and inotropic agents.
The insertion of an intra-aortic balloon pump has also been reported as being a successful resuscitative intervention due to left ventricular outflow obstruction that can result from a hyperkinetic basal segment and dyskinetic apex.
To summarize, many of the stressors noted to induce TCM can be seen in the emergency department. Beware of the patient with sudden onset chest pain and immediate stressors.
Use bedside ultrasound to help with the diagnosis. The echo would show akinesia of the mid and apical segments of the left ventricle.
As STEMI and TCM are clinically indistinguishable in the ED, Do not delay cath lab activation or withhold anticoagulation or thrombolytics.
Patients are prone to QT prolongation leading to torsades. Though they generally have good prognosis, be vigilant of any arrhythmias that may develop.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.